Wegener's granulomatosis is an interesting disease. It can present as the common cold, only more severe, but it is a vasculitis of the medium and small vessels and occasionally large arteries. Classically, Wegener's involves the sinuses, pulmonary, and renal systems. Limited Wegener's is different only in that there is no renal disease. Multiple organ systems may be involved, however, at some point in the course of the disease, and this includes the joints, the ears, the eyes, the skin, and the nerves. Pathogenesis of Wegener's is thought to be induced by inflammation or infection. On the upper left, we see a resting neutrophil, which is not yet expressing proteinase 3 or myeloperoxidase. With neutrophil activation, they are expressed on the cell surface as are adhesion molecules. The ANCA then bounds membrane-associated neutrophils, leading to production of inflammatory mediators and tissue injury. Presentation of Wegener's may be fulminant or could be in an insidious manner. That may include fever, night sweats, fatigue, loss of appetite, weight loss, and arthralgias. But the predominant symptoms are usually sinus. Of course, patients may have cough and hemoptysis as well. Physical examination findings may include a variety of mucous membrane ulcerations involving the hard palate, tongue, and also buccal mucosa. Patients may have preorbital cellulitis, scleritis, and also a variety of skin manifestations which often parallel other disease and other organ involvement. Saddle nose deformity may occur due to progressive cartilaginous destruction, causing collapse of the nasal septum. C. ANCA or cytoplasmic ANCA is positive in about 90% of Wegener's patients, and while it diminishes during periods of remission, it is not used to follow the course of the disease. This pulmonary function test in a patient with long-standing Wegener's is consistent with fixed obstruction of the large airways, which may be either intrathoracic or extrathoracic. A patient who has two of the following four diagnostic criteria has a 90% chance of having Wegener's. These include nasal or oral inflammation, pulmonary findings, microhematuria, or granulomatous inflammation on biopsy. The prognosis for Wegener's patients used to be quite poor, but now with cyclophosphamide and prednisone, the initial response rate is approximately 90%. Ideally, cyclophosphamide is given for a brief period of time, up to 3 to 6 months, and then replaced based on kidney function with either methotrexate or azathioprine. Milder disease may be managed with methotrexate and prednisone. Bactrim is prescribed as prophylaxis against Staphylococcus and also against PCP pneumonia. The good news is that with early detection we may be able to prevent the evolution to more severe disease and its consequences.